Hello and welcome. Thank you for joining the second convening of Unseen and Untreated, Confronting the Connections Between Heart and Kidney Disease, a Call to Action. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. And we're grateful to have so many leaders from healthcare, public health, clinical care, pharmacy, advocacy organizations, academia, industry, and community initiatives gathered here to jointly tackle a major and urgent problem. Here's the problem we're aiming to solve. According to the CDC, about 37 million US adults, that's one in every seven, have kidney disease, frequently called CKD. CKD is the eighth leading cause of death. CKD causes declines in quality of life. CKD is strongly linked to CVD, including heart disease, stroke, and premature death. Undiagnosed CKD progression increases the risk of sudden heart attacks and strokes. Alarmingly, 9 in 10 adults with CKD don't know that they have it. This is a tragic result of high-risk patients, those with diabetes, hypertension, and/or cardiovascular disease, not being referred for CKD screening. Hypertension is the second biggest risk factor for CKD, but a recent analysis found that only about 10% of US adults with hypertension had been screened for CKD with the recommended combination of tests. That's the problem. We, acting together, are the solution. This convening continues a collaborative effort that began in December with 3 partner planning meetings that brought together organizations and leaders representing a wide range of perspectives and expertise across kidney health, cardiovascular health, diabetes, prevention, pharmacy, public health, and patient advocacy. Those early discussions helped shape both the March 12th convening, in which you may have participated, and the work that has continued up to today. One thing became very clear during those conversations. We can no longer afford to approach heart disease and kidney disease as separate issues when science, the patient experience, and the public health burden are so deeply interconnected. Too many people with chronic kidney disease remain undiagnosed until very late stages, often after significant cardiovascular complications have already set in. Close your eyes for a moment. Imagine your father or mother, or a brother or sister, in an exam room. She or he is being told they have advanced kidney disease. It is the first time they've heard about it, and they face an immediate decision to go on kidney dialysis, which will make a huge impact on their freedom to travel and quality of life, or to die earlier. In your mind's eye, what does their face look like when they receive this news and that devastating choice? As one whose father faced that situation, I can attest that it is a rotten situation. Now, open your eyes. Thank you for joining this effort, because although cardiovascular prevention efforts still do not integrate kidney disease identification and management into routine care, we can change that. There's urgency for us to do so. Lives, people's well-being, and hundreds of billions of dollars in preventable healthcare costs are at stake. We're joining together, not simply to discuss the problem, but to advance practical strategies for action, collaboration, and implementation. 116 delegates representing more than 80 organizations from all across the country participated in the March 12th convening. We explored barriers to earlier detection, gaps in awareness, challenges with care coordination, opportunities for team-based care, the importance of UACR and EGFR screening, the role of pharmacists and public health partnerships, and promising innovations already underway in states, health systems, and communities. We heard strong agreement on the need for a shared framework to help align efforts and accelerate progress. That discussion ultimately helped shape the heart kidney health call to action that many of you have reviewed and contributed to over the past several weeks. Thank you for that. Today's convening is focused on moving that work forward. Our agenda will highlight examples of action already underway, strengthen collaboration across organizations, elevate practical implementation strategies, and create additional momentum around the call to action. The National Forum has long believed that meaningful progress happens when organizations work together around shared priorities and connect efforts in ways that create greater collective impact than any one organization could accomplish alone. That is exactly the spirit behind this convening. Thank you again for joining us and for your continued leadership on this critically important issue. Before we begin today's presentations and discussion, I want to briefly reflect on several themes that emerged from our March convening. One major takeaway was broad agreement that kidney disease must become more integrated into cardiovascular prevention and management. We heard repeatedly about the need to improve awareness of CKD as a major cardiovascular risk factor, particularly among high-risk populations, including people with hypertension, diabetes, and cardiovascular disease. We also heard strong calls to expand routine screening with EGFR and especially UACR testing, which remains dramatically underutilized despite its importance in identifying kidney damage early. Another important theme was the need for better integration across systems of care. Speakers discussed the importance of team-based approaches involving primary care, nephrology, cardiology, pharmacists, public health, community health workers, and health systems working together rather than in silos. We also heard examples of innovation already underway: clinical decision support tools and electronic health record prompts, pharmacist-led screening and referral models, state kidney initiatives and task forces, community partnerships, population health strategies, state-level quality improvement collaboratives, new opportunities through payment and delivery reform. Most importantly, there was a broad consensus that we need a shared framework for action. That led to the development of the Heart Kidney Health Call to Action. We deeply appreciate everyone who provided comments, edits, and recommendations over the last several weeks. There are three overarching strategies in the call to action to improve heart and kidney health. First, elevate recognition of the connections among hypertension, family history of CKD, cardiovascular disease, diabetes, and kidney disease among people at risk and clinicians in a variety of care settings, including primary care clinics, emergency departments, and walk-in clinics such as Minute Clinic. Second, increase screening, early diagnosis, and treatment of CKD in high-risk patients, those with hypertension, CVD, and/or diabetes. And third, ensure policies are in place to support screening, early diagnosis, and treatment of CKD and connection to treatment pathways when needed. Before we move forward, I also want to thank you for your patience and flexibility as we had to reschedule this convening more than once to avoid conflicts with several major kidney-related meetings and national events that emerged this spring. Between our March convening and today, there have been numerous important kidney-focused conferences, clinical meetings, and national discussions taking place across the country and internationally. We felt it was important not to compete with or conflict with other important kidney-related efforts, and instead support broader participation and continued momentum across the field. Thank you again for staying engaged in this initiative and with the call to action. Across organizations and convenings, several themes continue to surface consistently. We are encouraged by the degree of alignment emerging across organizations and sectors. That alignment creates a tremendous opportunity to accelerate progress together. You see that alignment reflected in the call to action. As we move through today's sessions, I encourage you to fully engage. Use the chat to connect, share insights, and learn from one another. We will also post helpful resources throughout the meeting. We will host a Q&A session after the open forum. Please submit your questions using the Q&A button at the bottom of your screen. This convening is being recorded. Your participation signifies your permission to record. We're now going to hear a couple of examples of how organizations are aligning their work with components of the call to action. These examples help demonstrate that many organizations are already advancing pieces of this work and that the call to action can serve as a shared framework for coordination and collective impact. Speakers' biographical sketches are in the program book. For the sake of time, I will give very abbreviated introductions, and I urge you to check out the longer bio sketches in the program book online. First, we're pleased to hear from Jill Ladd, Associate Director, Professional Engagement from the American Diabetes Association. I was fortunate to participate in the ADA's two-day summit on April 30th and May 1st in Washington, D.C. Jill will share a highlight of that event and other ways ADA is supporting heart and kidney health. Jill?
Thank you, John. We appreciate your involvement at our summit in Washington, D.C. Earlier this month. As you mentioned, we had the American Diabetes Association had a Driving the Change in Kidney Care Summit, which took place on April 30th and May 1st as an in-person convening in Washington, D.C. I think it's first important to think about the why, and why is the American Diabetes Association involved in chronic kidney disease? As John mentioned, chronic kidney disease remains one of the most underdiagnosed and undertreated complications of diabetes, despite clear screening guidelines and multiple effective treatment options. In fact, in the United States, more than 40 million adults live with diabetes, and approximately 40% also have CKD. Yet, nearly 9 out of 10 adults with CKD do not know that they have it. And this points to a significant disconnect between evidence and real-world practice. Therefore, the summit was designed to address that disconnect by bringing together the full ecosystem involved in diabetes and kidney care. So over the 2 days, ADA convened clinicians across specialties, researchers, healthcare system leaders, pharmacists, payers, advocacy organizations, professional societies, and community-based partners. We had more than 50 different organizations that were represented as panelists or attendees, which really underscored that shared responsibility that's required to meaningfully improve kidney outcomes. Importantly, this was a solutions-focused convening. The goal was not to revisit guidelines or restate what should be done, but to examine why implementation continues to fall short and how coordinated action across systems, sectors, and stakeholders can help close those gaps. As John mentioned earlier in his introductory remarks, there were a lot of themes that are coming across in these kidney convenings, and as he mentioned, we saw a lot of those same themes emerge through our summit as well. First, participants reinforced that gaps in CKD screening and follow-up remain widespread. Screening is not happening consistently, and when abnormal results are identified, they don't always trigger timely diagnosis, education, or care. There was strong agreement that screening alone is insufficient unless it reliably leads to action. Second, there was broad alignment around the importance of early identification and early intervention. Speakers emphasized that the greatest opportunity to slow disease progression and reduce downstream complication lies in identifying CKD earlier and integrating kidney health more intentionally into routine diabetes and cardiovascular care. Third, discussions made clear that CKD cannot be addressed by any single discipline or setting. Effective care requires coordination across the primary care, endocrinology, cardiology, nephrology, pharmacy, nutrition, diabetes care and education, and community-based support. Fragmentation across these settings continues to be a major barrier to progress. Fourth, communication and education surfaced as critical challenges, particularly for people living with diabetes who may not understand their kidney risk, test results, or the importance of early intervention. Participants emphasized the need for clearer, more consistent, and more person-centered communication across all points of care. Another important cross-cutting theme was advocacy, not as a single policy solution, but as a necessary level for system-level change. Conversations highlighted how awareness, incentives, quality measures, reimbursement structures, and national priorities all shape whether evidence-based kidney care is implemented consistently. Participants reinforced that advancing CKD prevention and early intervention will require continued advocacy across clinical, payer, policy, and community environments, alongside clinical and operational efforts. In addition to our panel discussions, the summit included an interactive in-person workshop that allowed participants from across sectors to engage directly with one another. This session focused on collectively reflecting on barriers, opportunities, and conditions needed for progress. And this portion of the summit reinforced that shared sense of urgency that John mentioned in his introductory remarks, and that strong appetite for collaboration and action across the whole kidney ecosystem. As next steps, ADA is actively synthesizing the discussions and insights from the summit, and this work will inform the development of an action plan aimed at moving the needle over the next 6 to 18 months. Now, while that plan is still in development, the summit provided an essential foundation by bringing the right voices together around a shared solutions-oriented focus. The Driving the Change in Kidney Care Summit demonstrated that when stakeholders across care delivery, advocacy, policy, and community engagement come together, meaningful progress becomes not only possible, but achievable. So thank you so much for allowing us to share about the Driving the Care and Kidney Change Summit, John, and we look forward to collaborating and working with you as well as others on the initiative moving forward.
Jill, thank you very much for that crisp summary. It was a privilege to participate in the summit. And as you said, it was very solutions oriented, solutions focused. And it was fun to be part of people who are so energized thanks to your leadership and your organization of, I think, a very productive summit. So thanks for that summary and for letting us know what ADA is leading. It's very important, I think, for us all to be aware that as we're gearing up this effort among cardiovascular health stakeholders, we are working in concert with and in parallel to a similar effort being led by ADA to bring diabetes stakeholders into the fold in a very similar effort. And together, I think we'll be able to accomplish much greater impact than if either the diabetes, metabolic health stakeholders, or cardiovascular health stakeholders were working alone. So, Jill, thank you very much.
Thank you, John. We appreciate the opportunity to be here today.
Next, we're pleased to hear from Chris Brine, who is the managing director of the American Society of Preventive Cardiology. Chris?
Thank you, John, for the opportunity to be here. The American Society of Preventive Cardiology is a multidisciplinary society. We have welcomed nephrologist into our fold, and we do understand the complicated patient, which we consider this to be. So thank you for allowing us to discuss this. We know that the diagnosis and the treatment of CKD is essential with the associated increased morbidity and mortality, especially the increased risk of cardiovascular disease and heart failure. It's very important for us. So what we are doing, I should say, is we are number one, we're very proud to sign on to the Heart Kidney Call to Action. So thank you for allowing us to do that and being a part of that. Additionally, in February of this year, our former co-editor-in-chief, Dr. Aaron Mikos out of Johns Hopkins, published an article in our journal, the American Journal of Preventive Cardiology, which was a call to action for our membership. And that call to action is to improve the standard of care for early diagnosis and management of CKD, to minimize the risk of this disease and progression and its complications, reducing CV risk, and ultimately improving patient outcomes. We look at this as alongside primary care clinicians, our cardiologists, our preventive cardiologists, they can also lead the way for these preventive efforts and implementation of guideline-directed therapies that can reduce the risk of both CKD progression and adverse CV outcomes. Additionally, we have major initiatives throughout the year that will be discussing this particular topic and pushing this call to action. Number one, we have a foundational lecture series called our Cardio Core Lecture Series. It's a monthly series where we educate our membership and beyond our membership on certain topics. This topic it has been added to our list of topics throughout the rest of the year. Additionally, we have a podcast series that we host a monthly called The Heart of Prevention. Again, similar to the Cardio Core Educational Lecture Series, this topic has been added to the agenda. We also have the largest fellows in training preventive cardiology academy in the United States. This program is hosted prior to our annual conference. We are bringing in 50 cardiovascular fellows that will be educated on many topics. It's a full day event. This topic has been added to the agenda due to its importance. Finally, our annual Congress will host over 700 of our preventive cardiology members. Again, this topic has been added and will be discussed at our event. Really appreciate the opportunity to be here. Look forward to any questions moving throughout this session, and thank you for having me.
Chris, thank you so much for that. The ASPC Annual Congress is one of my favorite meetings. It's so rich with content and people. So if you haven't been before, or if you're considering it and you haven't registered yet, I urge you to, as soon as this meeting is over, to go to ASPC's website and register. It really is an excellent meeting, and we're grateful, Chris, for the organization's leadership on this issue. You influence an awful lot of people in cardiology and beyond, a lot of practitioners and scientists. So we're very grateful that you're elevating the importance of kidney health and early diagnosis and treatment on your agenda. It's an important
Thank you.
signal that you're sending, an important action that you're taking.
Thank you, John. There's no longer cardiologists no longer just work on the heart, right? There has to be multidisciplinary approach, and these specialists need to work together. So thank you for having me.
Exactly, exactly. A link to the journal article that Chris mentioned by Aaron Mikos and colleagues is included in the program books resources section under the heading American Society for Preventive Cardiology. Jill and Chris's examples illustrate how organizations with different missions and constituencies can align around common goals to improve heart and kidney health. So we're now going to transition into our next convening segment, which is focused on moving the call to action forward through implementation, advocacy, and systems change. And we're pleased to welcome Miriam Godwin from the National Kidney Foundation. Miriam is Vice President of Health Policy and Clinical Outcomes. She has a strong foundation in health policy, clinical trials, and drug development, and has dedicated her career to advancing kidney care and increasing access to transplants. And I really am pleased to point out that Miriam walks the talk as she is a kidney donor. Miriam, welcome.
Thank you. And I'm so delighted also to be able to follow my colleagues from the ADA and the American Society of Preventive Cardiology. I love to hear about the signal that we're sending to different types of professionals, clinicians, other advanced practice professionals, and people involved in clinical care, because the more that we sort of tell the story of how important getting kidney disease screened and diagnosed is, the more we're going to move the needle. So that leads me into what I'm going to talk about today for the next couple minutes, which is the tools that we have for system change. So, I loved the remarks from my colleague at ADA, did such a nice job kind of like laying out what we want to achieve. So we know that we want earlier screening, we want earlier diagnosis, we want interdisciplinary care. We want support for the primary care clinician from, clinicians working not only in nephrology, but in cardiology, in endocrinology, in geriatrics, in obesity medicine. One thing that we know about the prevalence of kidney disease is that when we're talking about 1 in 7 US adults, these patients cross our health system. Every health plan, every health program, every clinician's office, every federally qualified health center, every hospital, every skilled nursing facility, everywhere that healthcare happens, that's where chronic kidney disease is. So we have a lot of levers that we can use to try to change the system. One is educating professionals. So telling the story of kidney disease, telling the story of how if we really want to optimize chronic care management, we really have to be paying attention to the kidney, because one thing we know is that, for our clinician friends, even when, the diabetes is being managed and the hypertension is being managed, that when the kidney disease shows up and when the kidneys are at risk, that's a sign that the management isn't going the way that we want it to go. And that patient is at really high risk for further progression and further kidney damage. So that's one piece of the puzzle. In my job, I work with tools of public policy. So I think about, how we can use health policy to kind of push the conversation forward. And there are a lot of ways that we do that here at the National Kidney Foundation. Most of our work goes through our Coalition for Kidney Health. I see lots of folks who are on the phone who I have the good fortune of working with. And the purpose of that coalition is to think of every tactic we can to try to drive systems change. So it can be everything from working with the U.S. Preventative Services Task Force to get a chronic kidney disease screening recommendation, all the way to quality measures. We know that the quality measures are a really powerful tool that we can use to close gaps, make sure that UACR is sent out, make sure that a diagnosis is recorded in the medical record, make sure that cardioprotective therapies are being prescribed, and making sure that our system can identify rapid progressors. Quality measures is one. Another one is all kinds of things that our friends in the executive branch can do. So thinking about what is the future of value-based care? As we think about where is primary care going and what is accountable care going to look like for primary care, is there a way that we should think about creating tracks that emphasize cardio-kidney metabolic syndrome or other kinds of chronic care management? We think a lot about benefits that already exist in the Medicare program, things like medical nutrition therapy and kidney disease education. So how can policymakers help to make those more accessible? If my colleague Elizabeth Montgomery were here, she would say that change is a process. There's never really a silver bullet when you work in public policy. You hope that there is one change that would make all the difference, but that's not really how it is. Incremental changes compound over time. Incremental changes across HHS, across Congress, across health plans, across states. Everything that we can do that moves the needle a little bit builds on, builds and builds and builds and builds. And hopefully, decades from now, we'll look back and see what a huge, huge difference we made. And it all starts with all of you, and it all starts now. Thanks, John.
Miriam, thank you very much. Really appreciate that and your insightful perspective. Gosh, I don't know where to start other than to say that your leadership is so valuable, your expertise, and we appreciate your collaborative spirit.
Yeah, can't wait to work with all of you. Thanks so much.
Indeed. One of the most encouraging developments that we continue to see is the emergence of state-level collaboration around integrated kidney and cardiovascular care. Miriam noted that there's no silver bullet in public policy, and I think many of us participating today, if not all, know from experience that affecting change at the federal level is a long, slow process. So the state level changes are very exciting because they can happen faster. And Texas has become an important example of how partners across state organizations can work together to advance awareness, screening, coordination, and coordinated approaches to chronic disease prevention and management. We're pleased to welcome today from the Texas Health and Human Services Commission, Benedicta Anikputa, who is the Clinical Policy and Development Coordinator, and Hanan Anwal, who's a policy specialist with the CKD Task Force Liaison in Specialty Health, and Independence. And from the Texas Department of State Health Services, Tess Kuchera, who's program specialist in Community Health Improvement Division, the Chronic Disease Unit. Thank you all for joining us today. Please take it away.
Thank you all so much for having us. My name is Hanan, and I'm the policy specialist for the kidney healthcare program here at the Texas Health and Human Services.
My name is Dr. Anaputa, and I am the clinical policy coordinator for Health and Human Services. Nice to meet everybody. As was discussed, we're from the state, and I had to, I think we're probably similar, a bit more similar to the feds when it comes to how fast change can get, but I'm happy to hear that other people think that we move quickly. That makes me feel a little bit of joy today. I'm here. We will be discussing the kidney healthcare program. That is one of the programs that we manage over here at me and Hanan are part of at Texas Health and Human Services, and we're under specialty health. The kidney healthcare program, which is also referred to as KHC, were a statewide program that was initiated in 1973 to help Texans with end-stage renal disease pay for specific treatments, surgeries, drugs, and insurance assistance. KHC is administered by Specialty Health in partnership with service providers to ensure eligible Texans with ESRD have access to life-saving and life-sustaining care. We provide limited financial assistance in the form of dialysis treatment, access surgery, out-of-pocket costs for medications, mileage reimbursement for travel to dialysis appointments, transplant services, and other ESRD-related medical visits. We also assist with Medicare premiums, deductibles, and copays. There are several provider types that are eligible to be part of our program. Physicians such as nephrologists, vascular surgeons, anesthesiologists, also nurse anesthetists, and facilities and entities like dialysis facilities, hospitals, pharmacies, and contracted Part D prescription drug plans. In order to qualify for our program, there are certain stipulations that have to be met. First and foremost is residing in Texas. And you also have to have a diagnosis of ESRD. It can't be an acute kidney condition. You have to have an income of less than 60,000 per year within the household, no matter what the household size is. And of course, you have to have a diagnosis of ESRD from a licensed physician. You must also be receiving regular dialysis treatments or have had a kidney transplant in the past. Um, and you must meet Medicare's definition of end-stage renal disease. And you can't be eligible for Medicaid, such as medical, drug, and travel. So an example is, let's say you get everything else from Medicaid, like medical and drug, but you don't have the travel benefit. You can still apply to our program. And if you're eligible, we might be able to assist you with your travel benefits. You also have to apply for Medicare because since we are a safety net program and a payer of last resort, you have to make sure that all of the other resources that are available to our clients are utilized before we can step in to assist. I'll turn it over to Hanan.
So here you can see a table of our client utilization broken down by benefit category. As of August 31st, 2025, our program has served 16,385 clients and have processed a total of 171,615 benefit claims. So quite a lot, and we are very proud and happy about that. Clients can receive benefits in more than one category. Therefore, the total number of active clients served does not represent the total number of benefit claims. KHC can table at dialysis clinics or participate at events for engagement days. We've been increasing our engagement efforts and have traveled to various dialysis clinics throughout Texas in the past year. And when tabling, we typically set up with our engagement materials and promote valuable information regarding our programs and details on the application and eligibility, and most importantly, get to connect with ESRD patients. I also wanted to touch on the Chronic Kidney Disease Task Force. The Chronic Kidney Disease Task Force was reestablished in 2019 through the Glenda Dawson Act, and the task force includes 24 members with representation from state leadership as well as a range of clinical and public health experts. This group brings together nephrologists, nurses, dietitians, educators, and other professionals to review data from state agencies, health systems, and research studies. Their goal is to assess how effectively chronic kidney disease is being prevented while identifying and managing that across Texas. The task force is also responsible for providing recommendations to the governor and state leadership. These recommendations focus on developing a cost-effective statewide strategy for CKD prevention, early screening, diagnosis, and long-term management, while also promoting the use of clinical guidelines among healthcare providers. The group organizes its work around several key focus areas through committees that are in the group. So these include improving public awareness and prevention efforts, expanding early screening and diagnoses, which we all know is very important, especially for individuals with risk factors like diabetes and hypertension, and optimizing treatments for stages 1 through 4 CKD, increasing organ donation through education, and supporting legislation that benefits individuals for that are living or at risk for having kidney disease. This is all we have. We're going to turn it over to Tess with the DSH's Heart Disease and Stroke Program. Thank you.
Thank you very much, everyone. My name is Tess, and as you heard, I am with the Department of State Health Services in Texas. Today, I'm going to be talking about the work that we're doing in Texas to improve cardiovascular health outcomes among our community members. All right. So we do this by working with federal and state partners to help health systems address social needs by connecting the people at risk for cardiovascular disease to social support services that will promote positive health outcomes. The work that we do with our partners includes, but is not limited to, helping clinics use electronic health records and standardized e-referral tools to find people at high risk for heart disease, improve care, and support their wellness activities. We also build care teams and partnerships with different types of healthcare and social service providers to find out what support patients need and help them manage their blood pressure and cholesterol. In addition, we connect networks of community, social need, and clinical care resources to help our community members manage blood pressure and cholesterol in accessible clinic settings, as well as in the comfort of their own home. All right, so two of the projects that we are working on are grants that we received through the CDC. We work with our national grant, our 2304 grant, and this grant aims to implement and evaluate evidence-based strategies which contribute to the prevention and management of cardiovascular disease in our populations of focus. And these populations of focus are those that are impacted by high prevalence of CVD. And these can be exacerbated by health disparities such as low income, poor healthcare, and unfair opportunity structures. Another opportunity that we have is our innovative grant, or 2304, and this grant, or my apologies, 2305, and this grant aims to prevent and manage cardiovascular disease among our communities at highest risk. All right. Another opportunity that we have in Texas to improve the health outcomes of our community members is through our Texas Cardiovascular Disease Learning Collaborative. Our Learning Collaborative was established to create a network of statewide partners to address social support needs, particularly for high burden populations. Our Learning Collaborative has the opportunity to host quarterly meetings and convenes in work groups, and they conduct the following. They coordinate statewide cardiovascular disease control and prevention efforts. They promote successes and resources that can be used to promote wellness activities in the community, and they can also encourage our community partners to work together. Other activities that we get to do in Texas is our regional hypertension collaboratives. This is a joint effort by our Heart Disease and Stroke Program and the American Heart Association. This allows our regional and local level leaders to meet. Those can include members in healthcare as well as community settings. They can come together and discuss various topics. They focus a lot of efforts around Target BP in the MAP framework, which is one of the programs that we emphasize and highlight throughout the state. And then they can share resources and assist as needed. Next slide. Thank you. And then we have our Texas Hypertension Control Summit. So this is where our Heart Disease and Stroke Program collaborates again with the American Heart Association to host our Control Summit. This is an annual event. The summit brings together national expert as well as Texas leaders to share the latest evidence-based strategies to help improve hypertension in both clinical and community settings across Texas. And then we have our Texas Council on Cardiovascular Disease and Stroke. This is a group that has a state plan to reduce the mortality, morbidity, and economic burden of cardiovascular disease throughout the state. They address risk factors and disparities, including high blood pressure, high cholesterol, tobacco use, and those related to age, race, ethnicity, and social economic status. Other areas of focus are to promote healthy behaviors, enhance quality of care throughout the state, and then improve those coordinated systems of care as well. All right, thank you so much. And I enjoyed telling you about the things that we're doing in Texas.
Well, Tess, Hanan, and Dr. Anakputa, thank you very much for the presentations. My gosh, a ton of work. So it was interesting to hear what you have going on, the services that you provide, and I suspect you, in addition to providing valuable services to Texans, you just provided valuable ideas to people from other states. So thank you very much. We'll now shift to another critical opportunity area, the role of pharmacists and pharmacy-based care in kidney screening and chronic disease management. Pharmacists are among the most accessible healthcare professionals in America, and they're uniquely positioned to help expand awareness, screening, referral, medication management, and patient engagement. We're pleased to hear from Ben Blummel, who's Executive Director and Senior Vice President for Research at the American Pharmacists Association Foundation. Ben, thank you for joining us.
Hi, John, and hi, everybody. Really glad to be here this afternoon to be able to share with you. So I think I'd like to channel John just a little bit and ask everybody to just close their eyes for a minute. We'll open them again soon. So as you have your eyes closed, just imagine that in our healthcare delivery system, we had the ability to have an access point with over 60,000 locations across United States communities where over 300 million visits through their locations occur every week. And those locations are led by doctorate level trained healthcare professionals, scientists who are widely recognized as medication use experts that also have skilled technical staff in their practices to support them. Now I'll ask you to open your eyes again so that we can talk about how pharmacists in community pharmacies are an important part of the solution for inventing the preferred future that we're all seeking here today. We have an evidence-based approach for team-based care that includes pharmacists that really can change the trajectory of patients' lives. And I'm going to give you just one example here this afternoon in the time that we have together. And it's from Project Impact Cardiovascular Health Plus and results that we presented at a summit in April. So we had 40 practices in 20 different states that comprise 2 Medicare administrative contractor jurisdictions within CMS. And those pharmacies implemented a social determinants of health system assessment with their patients. They implemented a stroke risk assessment. And then they conducted a EKG in-store in the pharmacies with a cardiomobile 6-lead device that within 30 seconds gives you a clinical grade EKG for that patient. And a really interesting thing happened, which built on a pilot that we had implemented during the pandemic, but now we see even more significant results at this level of scale. So pharmacists were able to identify people with atrial fib in the screening activity at over 3 times the rate that they would be expected to exist in a normally distributed population. So that's really mind-numbing when you think about it. And why is it that that can happen? Well, pharmacists have access to and are supporting patients with their entire medication list. They understand their medication profile. They can help people to make good choices about a program that might be right for them related to screening, early identification, and referral to a cardiologist or another specialist when they have an abnormal rhythm or atrial fib. And this sets us up and puts us in a position where essentially we can address this at a population level and deal with this in a really constructive way. Now, one of the big challenges that exists for our profession, like many of the other members of the healthcare delivery team, is that we have some really amazing technologies and systems in place today. We have interoperable electronic health records that, when used properly, can create proper information sharing and allow for that information to be utilized in productive ways. But in this patient-centered team-based care approach that includes a variety of team members, one of the significant challenges is that we don't have effective ways for attribution of those members of the healthcare team that were supporting the patient in actually achieving their results or their outcomes or their process measures. And that's something that we have to all work on together. And so we have to sort this out. So, one of the ways that we did this in Project Impact Cardiovascular Health Plus is that each pharmacist who participated was credentialed, just like their physician colleagues, by an NCQA credentials verification organization. And we paid them for the same CPT codes that their physician colleagues are using to actually get reimbursed for screening, identification, and referral activities. And then when those patients got referred back into ongoing monitoring and management programs in those pharmacies, we paid them the same way for those same codes. And our approach in these two Medicare administrative contractor regions was to show at some level of scale across all of these 20 different states and these geographies that it's time for all of us to pay attention, but in particular for payers who can actually, if they're willing to and they have the courage to change the way that care is being paid for and delivered, and to really make it possible for integrated, patient-centered, team-based care to occur, to have attribution, and to have proper payment for each of the members of the healthcare delivery team, in our case, pharmacists included, incredible change and outcomes can be observed. We're really excited about this, and we think that the same is true in chronic kidney disease. That these access points all across our country, that these trained healthcare professionals who are addressing cardiovascular and metabolic diseases are in a really strong position to help with kidney care and to be an essential part of the solution as we enter into more tactical discussions of how it is that we're going to actually achieve what it is that we intend to with these changes in care delivery today. So, John, I'll turn it back over to you, but that's the thumbnail.
Ben, that seems like a whole hand and just a thumb. That was really impressive. Congratulations on the results. And more importantly, thank you for the impact that you're making on so many people's lives. And I really liked the way you started off asking us to envision the preferred future. And certainly team-based care should be at the center of that preferred future because we know that it produces better outcomes for people and does so very cost effectively. So, Ben, we appreciate your sharing with us the impressive results of this latest work from the American Pharmacists Association Foundation.
Thanks, John.
All right. Well, Ben, thank you again. And we'll now move into the open forum discussion. We've invited organizations to share how they're responding to the call to action and what steps they're taking to move this work forward. Our goal here is to create visibility for action already underway, encourage collaboration, and perhaps most importantly, inspire additional momentum. We welcome both pre-scheduled participants and additional meeting participants who would like to briefly share their efforts. If you would like to speak, please use the Q&A button and include your name and organization so that we can queue you up appropriately. When called on, our team will help you turn on your camera and microphone. We ask participants to keep remarks to approximately 2 minutes so that we can hear from as many organizations as possible. And we're going to begin this part of the program with Rhea Suarez, who leads partnerships, strategic partnerships for the American Kidney Fund. Rhea, welcome, and please take it away.
Thanks, John, and thanks for the opportunity to share some of the work that we're doing here at the American Kidney Fund around heart and kidney disease. AKF works on behalf of the 1 in 7 American adults living with kidney disease, as well as those who are at risk. And we understand the important connection between heart disease and kidney disease. So our goal is really to highlight the awareness of CKM syndrome and promote early detection and improve long-term health outcomes. So we're committed to educating and supporting healthcare professionals and patients on CKM through various initiatives. And those include our Kidney Health for All website, our kidneyfund.org website, which hosts a wide range of topics, including a designated CKM page. And this explains the connection of kidney disease and CKM, some of the various stages of the syndrome, its risk factors, and action steps that can be taken to discuss CKM with your doctor. We also have our Kidney Health Coach program. So this is our peer-to-peer community health education program, which aims to prevent the onset of CKD and slow its progression to kidney failure. We actually have about 8,000 coaches across the country and worldwide that deliver kidney health information through various methods and diverse settings within their local communities. And so through this program, we're actually very excited to further the reach and impact of Kidney Health Coach through the launch of a new course, which is focused on CKM. So with the support of the American Heart Association, our new interactive training course is now available. And the course focuses on the connection of the heart, the kidneys, and the metabolic syndrome and provides practical steps that people can take to prevent and manage their risk. Additionally, as part of this program, up to 10 organizations will receive grants to participate. And these grants will help expand education and awareness within their communities. And these grants will be offered across the designated sites that align with AHA's CKM initiative. And we also have plans to expand to additional locations in the future. And then lastly, in partnership with the MAVEN project, we address challenges surrounding the early identification and treatment of kidney disease. So through the MAVEN project's ability to reach over 5,000 clinicians and 639 health centers, we will increase our reach to community physicians, primary care providers, as well as rural health providers, just more broadly in supporting continuing medical education accreditation, educational resources, and materials. And we'll also be creating a new CKM one-pager resource for healthcare professionals. So those are just some of our highlights. Thanks again for the opportunity to share.
Thank you very much, Rhea Suarez. We're now going to go out to Madison, Wisconsin, and hear from Sue Koob, the Chief Executive Officer of the Preventive Cardiovascular Nurses Association. Sue?
Hey, thank you, John. Yes, PCNA has really recognized, the importance of education and educating HCPs and patients about the link between the kidney and the heart for about as long as I can remember. So thank you for continuing to host these conversations and really bringing this conversation to the forefront. Team-based care is critical. So we greatly value the relationship we have with the National Forum, and I see Women Heart online here as well, and so many organizations that we work with. And so more specifically, I guess, PCNA as part of our organization really focuses on developing education for both HCPs and patients. And so at pcna.net, you can find quite a few resources in this area. We have the cardiovascular kidney metabolic syndrome, what you need to know patient tool. It's both in English and Spanish. We have a CKD heart failure screening toolkit. There's a kidney health equity continuing education course. And then we have quite a few podcasts on this topic as well. And that's at Heart to Heart Nurses. And those podcasts are just, 15 to 20 minutes. They're a great, easy listen. And they link back to a lot of the education that we have on our website. So thank you again for this opportunity. Really appreciate being able to share what we're doing in this area and to learn from all others. So thank you.
Sue, thank you for sharing what PCNA is doing, and as always for being such great collaborators. She said team-based care is the name of the game, and PCNA certainly leads the way in collaboration. So we appreciate
Thank you, John. So nice.
Thank you. Next up is Kevin Smith, who is the board chair for the Texas Kidney Foundation. Kevin?
All right, thank you guys. My name is Kevin Smith. I am the chairman of the board for the Texas Kidney Foundation. And wow, you guys are doing a lot. I really love it. So here you see a slide here. It's a busy slide, but it kind of summarizes what we do through our neighbors. We do several things, right? I'll highlight. We do our hope, helping our people. What does it stand for? Helping our people empower. Sorry, I panicked there. Helping our people empower, which is our transplant program. And then also the main program that we want to focus on today is our Neighbors Helping Neighbors model, which is our educate. We go into communities and we provide educational community health fairs, right? And our part of that is that we bring the various members of the community, agencies, et cetera, to service communities with a focus on, for us, bringing educational screenings that also include navigation, data capture, and follow through and trusted community settings. And those trusted community settings are generally in churches, community centers, various things around that we do there. Also, our screenings include blood pressure, glucose, hemoglobin A1C, cholesterol, EGFR, and a urine albumin to creatinine ratio, UACR, right? And then also where appropriate, we offer genetic screening as well. So as you see there, right? So we're screening, we're educating, we're helping people navigate the system because all these wonderful things that everyone is doing that I hear that you guys are saying, and I love the research and everything there. Oftentimes we see that it simply does not reach the community. So one of the things that we see as the missing piece in this whole system is the patient. And so we go out to the patient through networks and through community to educate the patient and the community as well, right? About kidney disease, its connection to cardiovascular disease. One of the statistics I always like to quote when at our events is that in Bexar County, and the same as in Texas, right? Cardiovascular disease is number one cause of death. And approximately 50% of those who die of cardiovascular disease also have CKD. And so we bring all the wonderful tools that you guys have created and generated. We compress those, bring those into the community. We bring those in through our screenings, education, and then after educated, helping people navigate, and then also capturing capturing data as well around that, and then follow through. So that's where we sit around. So as far as what we're doing, we're taking all this wonderful meeting and the wonderful information and knowledge that you have, and we take that everything that you guys are talking about, that we're talking about here today, and we provide it from go into the communities and provide it from a patient perspective. And our basic philosophy summed up is if my neighbor had issues with kidney disease and they knew that I also had kidney disease and had successfully navigated that, what would I tell them? What information would I provide them? What websites would I tell them? What questions would I tell them to go back in and ask their physician? And so that's the basis of our Neighbors Helping Neighbors model. It's not the only thing we do. It is a central part of what we do. And also I want to do a shout out to the folks from Texas. Another great thing that we see happening is individuals like ourselves, patients who are engaging the system and beginning to advocate on our own behalves, right? And then also advocating as well for the system, right? The system so it can expand its reach into local communities. So I hope that was good there. And my 2 minutes are up, it looks like.
Kevin, that was better than good. I'm really grateful to you for an important reminder, as I've been saying team-based care over and over. I haven't said what you just pointed out, which is that at the center of the team is the most important person, and that's the patient.
Yes.
So thank you very much for that. And I
One more
love,
add thing, John, if I could, I forgot because
yeah,
Tiffany would mad if
please.
I don't add this here. That we're expanding our screening. Most people just think, oh, they're in San Antonio, right? So we screened in Bexar County. We've also screened in Travis County this year. We're going to be expanding in our screenings efforts into Dallas County, Harris County, and McLennan County, which is Waco, Texas, in that area there. So we'll be doing screenings there as well in the 2026 year, taking the same model into those places.
Terrific. Glad you're spreading the screening capacity into those communities. That's very important and valuable. And love the neighbor to neighbor program because patients at times seems kind of depersonalizing, dehumanizing, and neighbor is a whole lot more human, and I think helps us relate to one another better. So thank you for your leadership on that as well, and congratulations on the good work of the Texas Kidney Foundation. Next, we're going to come up to Capitol Hill, where Selena Gora, who's the CEO of Women Heart, just completed giving a congressional briefing. And Selena, I'm really grateful to you for sliding over from members of Congress to this convening. So please take it away.
And we also at Women Heart believe that women no woman should face heart disease without the knowledge, tools, and support to act early. That belief is what makes our partnership with the Detect the SOS campaign so important and so timely. In the campaign, we are working with our partners like Men at Hearts, the American Diabetes Association, and the National Kidney Fund, with support from BI. Detect the SOS is grounded in a critical but often overlooked truth. As you all know, that kidney disease and heart disease are deeply connected. Too often, kidney disease is silent and undetected until it's already increased the risk of serious cardiovascular events. So together, we saw an opportunity to change that. This partnership is about closing that gap, bringing forward clear, accessible education that empowers people to understand their risk, seek early screening, and take action before a preventable condition becomes life-threatening. Through this collaboration, Women Heart is helping ensure that the campaign reaches the communities who need it most, particularly those who are disproportionately impacted by hypertension, diabetes, and barriers to care. We've been intentional about aligning messaging with the lived experiences of patients and ensuring that every piece of content reflects both scientific rigor and cultural relevance. Our role has been both strategic and mission-driven, and we are actively shaping content, guiding education efforts, and amplifying messages across national networks while maintaining full integrity of the Women Heart voice and patient-centered approach. At the same time, BI brings scale, national media, digital engagement, and broad awareness platform, allowing this message to reach millions. So importantly, this campaign is not just about awareness, it's about action. And hopefully together, we are exploring ways to connect individuals to screening resources and early intervention pathways so that knowledge translates into better health outcomes. At its core, this partnership reflects what we believe is the future of impact, aligning patient advocacy leadership with industry scale to drive meaningful medical change. Because we can help others detect something early, detect their risk early, we can move forward from silence to action. And we are not just raising awareness, we're saving lives.
Selena, thank you so much for that update. Thank you as well to Women Heart for being one of the first to sign the call to action. It's exciting to have Women Heart on board. You're such an important patient advocacy organization, and you do such important work to close the gaps in the sex-based gaps in cardiovascular, cardiometabolic health. So we're grateful to you for your leadership and for your collaboration.
Thank you, John, and thank you for all the support that the National Forum gives to Women's Heart Health and to Women Heart.
Absolutely. Well, now we'll go from Capitol Hill back out to Wisconsin and welcome Jen Koberstein from the Wisconsin Collaborative for Healthcare Quality. Jen?
Hello. Hi, I'm Jen Koberstein. I'm the manager of strategic partnerships at the Wisconsin Collaborative for Healthcare Quality, where I lead our work focused on chronic kidney disease and chronic diseases. We're a statewide healthcare quality improvement organization that works with health systems, clinics, and partners across Wisconsin to improve health outcomes through data measurement, public reporting, analytics, and quality improvement initiatives. WCHQ's response to the call to action focuses on translating national recommendations into practical quality improvement strategies that can be implemented across Wisconsin health systems. We have been working for several years to improve the early detection and management of CKD through statewide measurement, collaborative learning, and workflow redesign. In response to the call to elevate recognition of the connection between cardiovascular disease, diabetes, hypertension, and kidney disease, WCHQ has prioritized education and awareness across multiple care settings. We convene a statewide CKD improvement team that includes primary care physicians, nephrologists, pharmacists, and quality and population health leaders from across Wisconsin. Educational programming has focused on the relationship between CKD and cardiovascular risk, the importance of early identification, and the implementation of guideline-based care. To support increased screening and early detection, WCHQ publicly reports a new statewide diabetes CKD screening measure that examines annual eGFR and UACR testing among patients with diabetes. The measure is used to identify care gaps, compare performance across systems, and drive workflow improvement efforts at the practice level. WCHQ has seen the greatest success when practices use patient-level data to identify individuals missing recommended testing or patients with abnormal lab findings who do not have a CKD documented on the problem list. Several systems have implemented EHR prompts, standing orders, and audit and feedback processes to normalize annual CKD screening as part of chronic disease care. During the next 6 to 12 months, WCHQ health systems aim to increase screening among high-risk patients to ensure that patients with lab results indicating CKD have it properly documented on the problem list. We are also addressing operational barriers identified in the call to action through efforts to improve EHR-based identification of high-risk patients, strengthen referral pathways between primary care and nephrology, and support team-based approaches to screening and management. In addition, we're leading a statewide work to accelerate adoption of the race-agnostic eGFR across Wisconsin health systems. So thank you very much for having us today. You can find our publicly reported measures on our website. We also have a toolkit there that you could take a look at if you're interested. Thanks so much.
Hey, thank you, Jen Koberstein. That was a lot of information in a short time, and I really am excited about the work that you all have done. I think pioneering work on quality measures, and it's exciting to see how quickly you've moved, and perhaps more importance, how much impact you all have generated. So terrific work. I think we all can learn a lot from your leadership and your innovation in Wisconsin. Thank you. Yeah. So we do have a few questions coming in. If you have a question, please submit it via the Q&A tool in Zoom, and we'll get to as many as we can in the remaining time. This is the Q&A portion of our convening today, and the first question is for Jill Ladd. ADA has clear screening guidance for people with diabetes, yet testing gaps remain. What do you see as the biggest practical barrier to making UACR and eGFR testing routine in primary care?
Great. Thank you for that question. We did hear at our convening about how do you go about making those tests routine in the primary care setting. Different suggestions that came out as part of those discussions included EHR prompts, bundling those labs so that it's making it easy. Also talking about workflows. So I've heard in a couple of different convenings that we have had where having a stand-up meeting at the beginning of the day to talk through what patients you're going to be seeing and do we need to preemptively put in this lab order for them. So I think there's a lot of different solutions that we're exploring of how we can address this issue, because it is definitely an issue. 2 tests, 2 kidneys, ensuring that everyone understands what those recommendations are, but then also what do you do after that testing? Because sometimes we're finding that testing is happening, but the diagnosis isn't necessarily happening, especially at the level 1 and the level 1 and level 2. Sometimes it's level 3, and then people living with diabetes find, I'm already at level 3. How did that happen? So we're excited to dive into this work and see how we can make a difference.
All right. Thank you very much, Jill. Our next question is for Chris Brine from ASPC. And the questioner wants to know, how can preventive cardiology make CKD screening a standard part of cardiovascular risk assessment?
Yeah, that's a great question. Our leadership team discusses this regularly, and one of the focuses that we have discussed and will move forward with is a clinical practice statement, which is something that we put out as a society instead of an 80-page guideline or recommendation. We like to put together an 8 to 10-page document that our clinicians can and our members and non-members can look at over the course of the weekend and put into clinical practice on a Monday, for example. So that is something that we are developing and working on for our group that will help push the screening piece out there.
Terrific. That sounds like a great step, Chris. To our colleagues from Texas, to the three of you, seems like the state has built a statewide CKD effort. Oh, and the question just disappeared. A statewide CKD effort across or spanning public health, policy, and clinical partners. So, what's been the most important part of getting those groups aligned on a shared plan? How have you done it?
So, can y'all all hear me okay?
We can hear you,
Okay,
Hanan.
amazing. So we do have a biannual report that the task force is tasked with completing. So they meet throughout the years, and they meet with their committees. So they meet with their committees and they basically draft up recommendations that they believe that Texas should take, and that gets sent through the Agency of Health and Human Services and sent over to government relations for Governor Abbott to review. So that all is currently happening right now. I believe in the link or on the program, there is a link to the most current state plan. So if anyone's interested in reviewing that, it's really interesting, and that is due to be finished by the end of the year.
All right. Thank you, Hanan.
Mhm.
Let's stay in Texas. And the next question is for Kevin Smith. What messages has your foundation found resonate most with patients or communities who may not realize that they're at risk for kidney disease?
Good question. I'll answer that, but I want to go back to the one that was asked for the state of Texas because, and I'm sorry on that, but it's passion, right? And it comes from individuals in the community because my wife, Tiffany, is the president and CEO of the foundation, and she works a lot with Hanan, and those guys at DHS, and she is passionately driven. So it takes a community advocate to go and do what the state cannot do, right? And advocate and push for change and go to places and go to people who don't necessarily get along, but demand that, right? So that's the other missing piece there, right? And so to answer your question for the
Yeah,
community,
so policymakers and public health leaders can't do it alone. It takes
yeah,
community members and community leaders to pull
to
the ball
advocate.
over the goal line.
Yeah. And so it's the same philosophy we have there with going forth and advocating policymakers, advocating different people in the community, right? We make it simple, right? We don't,
Yep.
it's a very simple process of showing people through the educational screenings, right? What is EGFR and UACR? It's just words and abstractions until you show them with their own individual numbers, until you go to a pastor and you say, hey, here's what these numbers mean. Here are the number of people in your congregation that actually suffer from this. Here are some questions that they need to go and follow up with their primary care provider. And then also on our end, using community health workers to follow up and see, did you have the meeting? Were there additional questions that you have? It's very simple stuff there on that part there. I hope that answers your question.
Yeah, absolutely. Very helpful, Kevin. Thank you. Selena Gora, I know you're calling or joining us from Capitol Hill. Looked like maybe the Rayburn building where you were. I don't know if you're still with us
And
and
John, it
able to
looks like
answer a
Selena
question.
was not able to stay
Okay.
online.
All right. Thank you, John Barkus. So let's pivot to Jen Koberstein. How can measurement and benchmarking help health systems improve CKD screening without making it feel like just another reporting requirement?
Yeah, I mean, I think really the collaboration and looking toward high performers and learning what they do is what we have found works. We have one performer who's screening 93% of their diabetic patients, their patients with diabetes annually for CKD, and they have come and presented about the work that they're doing. And really, it turns out that everybody else is doing the same thing. They just have ingrained it in their culture. And so they've talked about how they've done that over the years, how they've made it a cultural norm that this is what it is expected. And so people are really motivated to reach that high level that their neighbor has in a county over and learn from them about how they did that.
Yeah, it's such an important point about building it into the culture. And then I think the other element that's there, Jen, tell me if I'm wrong, actually ties back to what Kevin Smith was just saying about the importance of community advocates. But it's about having that champion. And we've seen certainly with practices that excel in hypertension control that one of the keys is having a clinician who's a champion within to lead that work. Is that what you're seeing with kidney disease screening?
Absolutely. And we have champions that lead this work within the health systems at every level. And that makes such a difference in getting screening done. But again, partnering with communities, with community health workers, with families, with insurance companies. We've talked to insurance companies about how we can get the word out better. We've collaborated with them on screening. So it's an approach that needs to happen from all disciplines and with community involvement if we're really going to make a difference.
Yeah, absolutely. So I know people like to say data driven, but it's really to a great degree champion propelled. And speaking of champions, I want to call on our friend Dan Lackland from the Medical University of South Carolina. Also, leader of the World Hypertension League. Dan, I know you were coming from another meeting. Have you been able to join?
Looks like we can just elevate Dan to be able to speak. May take a moment.
All right.
And I think sometimes we fail to remember that patients are visual, and visual content is far more effective than text. I tend to be a text guy myself, right? But visual, things that are visual. I think the American Heart Association's stratification of the blood pressure, what those numbers mean, and that's the most effective tool. It cuts through anything that we could say or do when we show people this is what your blood pressure numbers are landing, right? And then that begins to stress the importance of doing things like do a log before you go.
Yes.
Also educating people, also helping not just the individual participants, but also their communities at large, that if you have someone in your congregation who continues to have uncontrolled blood pressure, that's not normal, right? Then to go back and ask, hey, maybe do you need a combination of medications, and provide them, hey, here are 5 possible classes of medications that can be combined. Go back and ask your physician about that. And then that's where that education with champions who are in the practice, that's what they do, right? Is try to advocate for people. When you have those, it's coming from within the practice and from outside in the community. That's when we find those things are meeting, that are having the best impact in those communities.
Yeah, Kevin Smith, those are a couple of really valuable points about communication and methods of communication and the importance of messengers. So thank you very much for that. The next person up, Dan Lackland, I know has spent a tremendous amount of his career working on those messages and helping to develop messages that resonate in cultures all across the world. Dan, we know you are coming from another meeting. You're a leader of the long-standing cardia study, and you were meeting with your colleagues who are running that important study. We appreciate you hopping over to join us.
Certainly. It's certainly a great, great pleasure to be here, John. I think this is such a tremendous topic. And just starting out from the beginning, the kidney, the heart, but also put the brain in there too. And the common denominator there is blood pressure. And many neurologists, many cardiologists, many nephrologists tell their patients the most important thing I can do for you is to control your blood pressure. Number one, right there at the top. And we feel like that is a great denominator. So just as we're just here, but it's the communication that lets us be where we need to be. Right now, if we look and say half the adult population is hypertensive, and really only 1 in 5 of those at best have their blood pressure adequately controlled and ready to go, we have a long way to go. But we also have the opportunity, I think, and the resources to do things to improve this, including all the technology and things, AI, and electronic health records that can also improve that communication that we have between the patient, the individual, and the healthcare team.
Dan, thank you so much for that. Yeah, hypertension, gosh, I'm reminded of Keith Ferdinand's 3 Ps of hypertension, that it is, as a risk factor, it's potent, it's prevalent, and most importantly, it's preventable, perhaps most hopefully. And certainly, kidney disease, as it connects to hypertension, is something that also is preventable, or at least its progression is.
The progression is correct. Beautifully said.
Yeah, so we greatly appreciate your leadership in calling attention to these preventable risk factors and helping to drive action to change the trajectory.
Yes, absolutely.
Thank you very much, Dr. Lackland. Well, as we begin wrapping up today's convening, I want to return to the importance of collective action. And several of our speakers made very valuable points about it. The Heart Kidney Health Call to Action is much more than a document. It's a framework to align organizations, connect efforts already underway, identify shared priorities, and accelerate meaningful progress. No single organization can solve this challenge alone, but together we can elevate awareness, improve early detection, strengthen systems of care, and reduce the tremendous human and economic burden of kidney and cardiovascular disease. I encourage you to continue reviewing the call to action and consider joining the American Society of Preventive Cardiology, Women Heart, National Forum, and others as a signatory. Signing the call to action signals a commitment to closing the gap between the large number of people at high risk for kidney disease and the far smaller number who are screened, diagnosed, and treated. Second, it adds your voice to the growing national call to improve early diagnosis and treatment for people with heart and kidney disease. And third, it creates opportunities to align your efforts with others and amplify and magnify collective impact. A commitment packet will be shared with you later this month to support your review. It will include an executive summary, board briefing materials, a clear overview of the commitment, a flexible menu of actions, and ready-to-use tools such as a sample board resolution, communications resources, and a simple sign-on process, all designed to make participation straightforward and valuable and impactful to your organization. I want to recognize the importance of engaging additional clinical and professional organizations, including continued outreach to partners such as the National Medical Association and others whose leadership is essential to advancing equitable care and outcomes. And I want to thank everybody again, particularly our speakers, participants, partners, and attendees for contributing your time, your expertise, and your leadership today. I am very grateful to our sponsor, Boehringer Ingelheim, for making this convening and the one on March 12th available to you for participation at no cost. And today's discussion demonstrated that momentum is building, collaboration is expanding, and organizations across the country are ready to move from conversation to coordinated action. We're excited about the progress ahead and the opportunity to continue building this national movement together. We look forward to continuing this work with you.